DYRK1A conference, so I'm really happy to be back and talk to you more about what Searchlight has been doing. We do have a booth outside for those of you who haven't yet participated. I'm very honored to be invited back this many times and also to be following with other researchers who I hope are also collaborating with us and using our data with families who are participating in our project, and also other wonderful talks that I've heard over the last couple of days. So it's wonderful to be at this meeting. So just to get started, I have a lot of the information that I've presented. I've actually heard a few people talk about in their data sets. So Dr. Newhouse, who spoke this morning, she shared a lot of data that we've essentially replicated and also done in collaboration with her in the Tiger study over the years. And a lot of the information that Dr. Glass presented this morning is really consistent with what we're seeing. So I hope that when we dig down into what we're actually doing, we'll be able to see that a lot of what we're seeing across these research studies, while they are unique and different in their own ways and maybe how we're going about it, we're seeing a lot of the same things within DYRK1A. So for those of you who aren't involved in the Searchlight study, we are an international research program. So anyone with actually almost 200 genetic conditions that cause autism or developmental disabilities are invited to participate, of which DYRK1A is just one of those conditions. But we do offer participation to many conditions. The criteria is that there is a genetic change that causes developmental disabilities, and DYRK1A is eligible to participate. Because it is international and a large study, it does take a bit of a village. So there are multiple of us who across both the foundation itself, the Simons Foundation, Boston Children's Hospital, and then also my team, which we're based out of Pennsylvania at Geisinger. And then we also do have a community advisory committee with other parents and self-advocates who are impacted, their family or their children or themselves, by a rare genetic condition that leads to learning differences. So what are we trying to accomplish at Simons Searchlight? We have phases of participation. So ideally, we want to try to better understand exactly what individuals who have specific rare genetic conditions look like over time. One of the major reasons for doing this and participating in not only Simons Searchlight, but Combined Brain and Rare X and Tiger, all of the studies that are interested in DYRK1A, is that understanding what we would call the natural history of DYRK1A. That is, if we do not have a specific therapy specifically just for DYRK1A, what does it typically look like over time? And that is largely the goal of Simons Searchlight, but also to empower other researchers, collect data, collect biospecimen samples, partner with other researchers who are doing similar things so we can better understand what Simons Searchlight is, what DYRK1A is, and what it means so that we can better impact the future of the research directions. So you may have heard of the Simons Foundation broadly, and you might actually be participating in more than one study. So the Simons Foundation is actually a research organization that spans multiple different arms. They have an arm for mathematics, much more basic science. And then SAFARI, which is the Simons Foundation Autism Research Initiative, that is just the arm that is focused more on autism, but with a focus on genetics. So the Simons Searchlight study, while we are recruiting individuals who have an autism diagnosis, you don't have to have an autism diagnosis to participate in Searchlight. We call it a genetics first study, meaning that we want to see what genetic syndrome you have, and that enrolls you in the study, regardless of whether or not you have autism. If you do have autism, you may have come in through the Spark arm. So the individuals who have an autism diagnosis might enroll in a different study, also associated with the Simons Foundation, but more focused on autism, while Simons Searchlight is mostly focused on genetics. So the goal really is to try to build synergy between a variety of different projects. So when I talk about the SPARK study, which is individuals who have autism, the Simons Foundation tries to facilitate genetic testing for those families. And if we find that they have a genetic change, like DYRK1A, that might be the underlying cause of their autism spectrum disorder, we can then move them into Searchlight and enroll them in a genetics focused study and also make sure they find their genetics focused community like this one. Oops. So I mentioned already that we have nearly 200 genetic changes that are part of the Simon Searchlight study. Here you are right there, so little blocks around you. DYRK1A has been part of our community now for many years. So what are we trying to give back to families and what are we trying to provide to researchers? So we do want to facilitate investigation by researchers. This is one of the core premises, I think, of Simon Searchlight, is that our data is accessible and free to any researcher who wants to have it. So if you enroll in Simon Searchlight and you meet another researcher who thinks that our data might be helpful for their project, they can sign up with us. We will help them do that, and we will help them collect and collaborate to give them that data at no cost to the researcher. The biospecimens get a little bit more complicated because there is some storage costs involved that at very low cost to researchers. But the surveys that you fill out, anyone can ask to have those, and we're able to provide those to other researchers for free. We also want to make sure I'll lump these two together, that it's longitudinal. So we will follow up with families every year. As many of you may have realized and was alluded to earlier today in one of the talks that I heard, a lot of the families who are diagnosed with DYRK1A tend to be on the younger side. And that is essentially a cultural change of how we go about getting genetics for families. So in older days, we wouldn't often get genetics on individuals because insurance wouldn't pay for it and it wasn't common practice. So what we know about younger kids who have DYRK1A is far more rich than what we know about older kids with DYRK1A, because less of those individuals actually had access to genetic testing when there was a recognition that there was a developmental concern. I think at least in the United States, we're making some improvements. Some other countries have made even more improvements than we have in terms of getting genetic testing for older individuals. So we're moving in the right direction, but still the amount that at least we know about what DYRK1A looks like at 30, 40, 50, 60 years of age is more limited than what we know about how the kids look when they first get diagnosed. So that's one of the reasons we want to make it longitudinal, and we want to make it feasible and scalable for us to do, because DYRK1A, even though you have a large number of families across the world who have DYRK1A, it's still a rare disease. And so every single person matters. We do have now 5 languages where people can participate. So if you have individuals in your community who are from Europe or from South America, anywhere, we're trying to find ways to make that participation feasible. Right now I have brochures out there in English, Dutch, French, and Spanish. Those are the languages where you can participate. We also are working on Italian and Portuguese as our next steps, and hope to add more languages. Anybody could join and be a part of the broader research group. So, and this is not dissimilar from a presentation I heard earlier today about the kind of information that we want to be collecting. So we want everyone to give us just base. So when I say baseline assessment, that means the very first time that we meet you as part of our study, this is everything we want to collect. And then for the longitudinal follow-up, what do we want to make sure that we get every year? So we want just basic information about your child and their genetic status. We want to understand their medication and medical history and medication use, both at the beginning and as we follow up. what diagnoses they have, whether or not they've had seizures, which is relatively common in the DYRK1A community to have seizures, what medications have or have not been effective for that. We collect information about sleep and then also about development and behavior, including at the Vineland is day-to-day living skills like toilet training, getting dressed and undressed, feeding yourself, how individuals are communicating, if that is verbally or through a device, or as I've seen many of your kids, what I would call a multimodal communicator. So they might use a combination of verbal speech and something else like a device or sign language to help us understand what they're trying to say. Behavioral concerns, be that ADHD type behaviors or autism related behaviors as well. Quality of life. And then every year, we also just want to get a brief update so we can better understand when, if developmental milestones are delayed, when do they typically happen, specifically in DYRK1A? So that's the purpose of some of these. Other things that we're planning on, additions over time. So we are trying to get a way that we can access if any of your children have had either an EEG or an MRI. Is there a way that we can collect that data and share it back? That is logistically complicated because many of you probably got that at a hospital system, and getting that data can be difficult, but we're working on trying to identify how we can get that. And then here are a few others. So understanding what your different community needs, motor skills, developmental milestones as well, and more severe behavior issues too. So just for those of you who have participated, just updates is that you used to probably get a phone call every year and talk about what was going on with your life and what was going on with your DYRK1A child. We've transitioned that to be entirely online, but every single survey is reviewed by a genetic counselor after you submit it. And if they have questions and say, wait, this doesn't match, this doesn't make sense, then they will call you. So that's a lot about capacity building. So as we have more families who are coming into the Searchlight study, it's been hard to do phone calls with everyone, but we are trying to find a more streamlined way to let us have you give us some information. We can identify if we have any questions about that information and then follow up with you with a genetic counselor. And then I mentioned this earlier, but the observer reported communication ability, or the ORCA tool, which was developed by another rare disease community called Angelman syndrome. They developed this tool to identify progress in their own kids, and it seems like something that we can apply broadly to other communities who have trouble with communicating, and it goes beyond just verbal speech, so we can monitor progress. So if you are part of our study, here's what you would see if you log in. So you make an account and you would see exactly where you were in the steps. So what do we need to do and what do we have to do next? And then if we do offer compensation for participating and getting your surveys done. So there's ways to go about that. I'll let you register, log into your database. We do have coordinators who can help with that. There are business cards for our coordinators on the table just outside. So if you had questions about where you were in the process, we have people who are able to help you. In addition, right now we're doing this quarterly, but we're hoping that within about the next calendar year, we're going to be able to do this on an ongoing basis. So right now, quarterly, you can receive information about your community. So what's up with DYRK1A that I should know? And also, where does your child fit within that picture? So relative to other DYRK1A families, does your child have more or less concerns, and in what area? And then, of course, we're trying to do these presentations at conferences to let families know what we know about your kids. In addition, for any of the researchers in the room, or if you are connected with a researcher who was not here today, we do have a program called Research Match, where researchers who want to reach out to your community can actually reach out to everyone that we know who's in the DYRK1A community. So I will use, I don't think there are a ton of researchers here today, but just to plug that if you have a researcher who's very interested, who wants to capitalize on a research database where they can actually say, hey, will you please email everyone that you know in your database who has DYRK1A? We have a way to facilitate that. And they can just reach out to us to find out that information. In addition, and for those of you who were here yesterday, I want to specifically plug this too, is that blood samples can be really important, especially if you're in the preclinical trial phase of thinking about targeted treatments for DYRK1A. And there were a lot of talks yesterday about that preclinical phase, be that mouse models, be that doing organoids, and also the use of induced pluripotent stem cells. We're not collecting blood today at your family meeting, but we have in the past. And so we do have a rich biorepository of individuals with DYRK1A who have donated their blood here at a similar conference. You can also do it from your home. So you don't have to necessarily be at a DYRK1A conference to donate a blood sample, but if you wanted to donate a blood sample or have your child donate a blood sample, we have a partnership with 2 different remote blood sample labs now. One is Quest Labs, where you actually have to travel to the lab in order to participate, and then another where they would actually participate and come to your home. And then we also have a partnership with Combined Brain. And so we call it 1 SIG 2 studies. So if we're here together with Combined Brain, we won't have to stick your kids twice if we really don't care to have done. But we can draw blood, and we have a relationship with them where if you wanted to participate in both, you could do that with only having 1 blood draw. Typically, we only are able to offer that at a conference like this, but we will hopefully see where those next steps go. So the key concepts to know is when you donate your blood, what happens to it? So it does go into our biorepository, and different researchers might want different forms of blood based on what their research questions are. And the one that I want to focus on, because it was talked about a little bit yesterday, is we call it induced pluripotent stem cells. What those are is that they can take blood from your child or from you and turn it into a stem cell through a process that I do not do. So I won't go into any form of detail, but they can turn your blood into a stem cell. What a stem cell is an undifferentiated cell. So you can turn it into a neuron. You can turn it into a kidney cell. You can turn it into a liver cell. They can turn it into any different type of cell type that they want. And they do it through a blood draw. And a process that we partner with the New York Stem Cell Foundation to do this. So if you have donated blood historically at a DYRK1A conference, you do sign an extra consent form that says that we can turn that blood into a stem cell, and then that stem cell could be available to a researcher who wants to turn it into any kind of cell type they want, including organoid. And then do a vision, better understand how the brain, how the heart, how other things in DYRK1A develop. Right now, we are able to offer that to a lot of different families because of the partnership with the New York Stem Cell Foundation. We're able to offer it at a pretty low cost, so it's only about $200 for the researcher to get the stem cells, which is pretty low cost relative to the amount that it would cost the researcher to do it themselves. As you can see, we have hundreds of requests to get our data, including researchers, some of who presented here, Dr. Newhouse being one of them, who published publications using data that you've provided through Simon Searchlight. Right now we have over 100 publications that have used data from Simon Searchlight, including data that's ultimately been published in Gene Reviews. You do have a DYRK1A Gene Reviews. If you have not accessed it yet, I would highly recommend using Gene Reviews as a way to communicate with teachers and doctors and others what we know about DYRK1A It's essentially a group of researchers who take all the data that we know about DYRK1A, synthesize it into one document that is friendly for doctors to, and I would say even teachers or others to actually read and process it. Here's everything we know so far. By virtue of submitting a gene reviews, you are obligated to update it every 5 years, which isn't the most fun thing. However, you can check back on a regular basis and see if there's been a new iteration that's been published. So just as a quick, I'm going to go through these quickly, but just as a quick look over the last about 5 years, there have been 8 publications using our data on DYRK1A, and these are other studies that have recruited families from our cohort of DYRK1A. So like I mentioned about Research Match, other families that have been recruited through us, including the players. So right now, we actually have 68 DYRK1A participants. I'm going to just gloss over this slide briefly, but there is a request for funding out right now. It's $300,000 over 2 years to use our data. And that's money that the Simons Foundation gives to your researchers. So they just need to submit an application. It's due September 4th. Skip over this one. So what do we know? What's actually in our database with DYRK1A? I think it's been 2 years since we've done an update for you guys about what's been in our database. But overall, there are 83 individuals who have signed up who say that they have DYRK1A and have consented to be part of our study. 69 of them have actually given us a lab report. That is a required part of our study. Those are all manually reviewed by a genetic counselor to make sure that the variant is accurate. In addition, we're working on a pipeline now where if some individuals in this room or individuals you know in your Facebook group might have what was called then a variant of uncertain significance. So they have a change in DYRK1A, but we don't know what it means yet. Does it cause a problem with DYRK1A or is it benign? So we're starting to do an annual review of all of those genetic changes so that we can let families know, yes, DYRK1A is your answer, or no, maybe it's not your answer. Are you in the right community for the research that you're doing? And then we have families, you can see sometimes there are a bit of a drop off here, so then medical history, interviews starting to fill out forms, and then for some families providing a blood sample. So here's who we have so far. So right now, the only variant, this is the DYRK1A gene, and here are where the variants are located. And the variants that I'm including in this presentation are only the variants that we know are either pathogenic or likely pathogenic. So they're not the variants of uncertain significance where we're not sure if that variant is causative of the symptoms or not causative of the symptoms. One thing to note here is that most of you have in your child or in yourself have a genetic change that no one else has. There are very, very few where there are maybe 2 or 3 people who have the exact same genetic change. So what does that tell us? One is that it's really important to try to have everyone participate as much as we can because you are all very unique. 2, even though the genetic changes are different, a lot of the kids, as you interact with them, have a lot of similar features, and so it may not matter as much where your variant is located, but it might. And we want to try to better understand where your variant is located and what that might mean for the presentation of your different kids. Right now, that's something that we don't understand very well. Why some changes happen really early on in the gene, why some happen later, and which ones are necessary, which ones I'm wondering, Grace. We don't necessarily know that a change here is any different from a change here. As long as it's pathogenic, you might actually see that disabling the DYRK1A gene, it doesn't matter where the variant is located, it might cause very similar outcomes. Here's where we are. So mostly in the US, but starting to build a more international community. Here's where we are in the States. And here's the different samples that are available. So overall, we have samples for iPSC, whole blood, saliva, DNA, and then different cell lines. Actually, I overestimated how much we charge. It's $124 a sample for researchers worldwide for the induced pluripotent stem cells, if they have interest in that. Oh, and I should add, we have 12 research groups that are already using the blood that you have donated. Okay, so, and I think I'm probably running out of time, so I will go through this quickly again, mostly because a lot of the different studies have shown similar things. So the medical history interviews, we have 37 people overall who have gotten through the entire medical interview, and you can see that the age range, like I mentioned earlier, is heavily slanted towards the younger kids. So we don't know as much about kids who are over 30 than we do, say, for kids who are under the age of 20. Most individuals are about age 10 in the DYRK1A community who've gone through our medical history interview. And here's what we commonly see. And again, based on the talks I saw earlier, I don't think any of this will be a surprise. So language delay and impairment, we just had a whole great talk on that. And also intellectual disability and developmental delay, about half also having an autism diagnosis. But then some other things that are less common, but we see present, some individuals having a diagnosed anxiety disorder, a diagnosed symptom, diagnosed ADHD, or diagnosed OCD. Now, that's not to say that some of your kids might not have symptoms of some of those conditions, because sometimes we can see kids that what we would call subclinical. So they might have symptoms, but maybe someone wouldn't necessarily diagnose that. But these are the more common diagnoses that we see as well. In terms of overall medical issues, neurological comes up really at the top, and I'll show you on the next slide. It's largely related to some of the hypotonia and movement disorders that are really common in kids that we can see. A lot of gastrointestinal issues. The Dr. Newhouse, who presented on the Tiger study earlier, her and her mentor, Rafe, who many of you may have met as being the original leader of the Tiger study, did some great work about how low tone can actually manifest in the GI system. And so by virtue of having low tone, high tone, motor discoordination, even though we can't see it because it's in the intestinal tract, it actually is a red flag that we will see more constipation, more GI issues, because those muscles, they're on the inside, but we can actually see it, but they might still be causing issues. So here again, neurological issues. So the most common being the small head size, which for often is one of the first things to realize. Movement disorders are really common and very variable, with low tone, but also high tone being diagnosed, and then other motor conditions. Speech also, the apraxia and dysarthria also being a form of a motor condition that you can see. Some even being diagnosed with cerebral palsy. Sometimes I'll hear families say, well, my child was diagnosed with cerebral palsy, or my child was diagnosed with autism, but actually they had DYRK1A. And that's not the right way to think about it. That's the cause. So those are behavioral diagnoses. So your child presents with what looks like cerebral palsy. They present with what looks like autism. And then when we try to figure out why did that happen, then we find out that it's DYRK1A. So to encourage you to not think about it like a misdiagnosis, it's just what the clinician can see versus why it happened. And DYRK1A is the cause of the overall picture, but it doesn't negate the diagnosis of cerebral palsy or autism or the other diagnoses we may have. So about half of the individuals, a little over half, also present with seizures. Most of them tend to be well managed and present, and similar to a talk I saw earlier, present relatively early in childhood. And I think this was almost exactly what Dr. what we referred earlier today was that average age of seizures being seen around, being seen relatively early in life, between 5 months and 6 years, and then control around 6 years of age. That's not to say that you should just say, okay, we're past 6 years old, there's no worry about seizures, because we do know that, especially during puberty, it's another kind of risk zone for seizures. So, but by and large, most kids will present with seizures relatively early in life, and most will have seizure control relatively early in life. I will gloss over this one a little bit too, because I believe out of but having vision problems is relatively common. And then also short stature and failure to thrive. So failure to thrive being that not growing typically in the very early infancy period, not gaining weight, and then ultimately ending up with short stature as older children. We have orthopedic issues are not incredibly common. We do have a number who report scoliosis. Again, heart issues are not incredibly common, but we do have a handful that do report some heart concerns. And then medication issues, mostly for GI problems and mostly for anti-epileptics for seizures. Looking at that, most individuals have achieved control on Keppra, but we do have some who report having control on valproic acid. But Keppra was the one where most individuals did find control. And then finally, in the last few minutes, this is the Vineland Adaptive Behavior Scales, which looks at overall development and looking at it over time. So just to orient you to the next few graphs, the dotted line is the age at which most individuals attain a skill, and the solid line is where the DYRK1A children attain skills of the ones where we actually have data. So you can see that overall, for the level of functioning of the child, they do tend to gain skills, but they do tend to attain it later, and it's more of a slow and steady trajectory. The same is true for personal care skills, slow and steady kind of trajectories, but a steady trajectory nonetheless, wherein a lot of individuals are likely to be able to attain many of these skills. And finally, social development, again, slow and steady, a little bit slower than the other areas. And finally, what are the behavioral concerns that you report, even if there is not a diagnosis? So many of you are saying that a lot of your kids are hyperactive, moving on, have trouble focusing, chewing on non-food items, and have difficulty waiting. Older kids, again, so even if they don't have a diagnosis of ADHD, showing symptoms related to ADHD and OCD and anxiety. So overall, as a summary, the most common issues are here with intellectual disability, language delays, vision problems, seizures, small head size, high and muscle tone differences, and then other issues which are less common, but we do see reported on the other right. And I will go ahead and stop because I believe I'm well over time. And I will be out at the table. I'll also be at your dance party later. So if you have questions, I'm happy to answer them. Yes.
You can do the plug-in.
Yeah.
That's the only way that we're able to get the data and understand more is when we all work on research. I know sometimes it's hard because we have our talks, we have our students here, we have here the doctor, and so we have a bit more time to fill out the paperwork and participate. But we appreciate, thank you all the things that do, and encourage the ones that are not yet to consider, because our data, everybody together is going to be able to understand more and advance the research the way that we want to improve the quality of life for our kids and adults.
Yes, thank you. Yes, and I'm right outside. My table's outside. There are business cards out there and cards and stickers and things that you can take if you want just a little reminder. Come participate.